My name is Moriah Johnson, and today I'll be discussing outpatient recovery following subdural hemorrhage due to a fall. As a general introduction, we'll go over just a couple of key terms and the population that's going to be discussed. So first there's subdural hemorrhage, which is just bleeding within the anatomic arachnoid space, so between the brain and the skull, often due to a blunt head injury, and then in geriatric populations, falls are the greatest indicator and risk factor. A subdural hematoma, the acute presentation is headache, nausea, vomiting, altered mental status, seizure, and/or lethargy, but the chronic presentation, pretty similar, although it has decreased consciousness, motor and/or neurological deficits, aphasia, and personality changes. So for intracranial bleeds among geriatric populations, one study found that in their emergency department, around 1 in 20 geriatric patients presenting after a fall have intracranial bleeding. And then another study found that of the patients presenting to their emergency department, they were associated in geriatrics with higher mortality. 74% of injuries were actually due to falls, and they were more likely to be discharged to skilled nursing rather than to home. So in the literature review, there were factors significantly associated with chronic conditions, age, anticoagulation medications before injury, administration of procoagulants, presence of other coagulopathies, low hematoma density at discharge, hematoma thickness on admission, and degree of midline shifting. In another study, patients younger than 50 typically presented with signs of increased intracranial pressure, whereas older patients, so older than 50, were more likely to present with neurological deficits. Another study looked at 209 cases of chronic subdural hematomas. 72 were observed without surgery, so conservative care and medications. Of the 209 cases, 130 were discharged to rehab and skilled nursing, and 44 were discharged to home. Now, those factors are important because they actually predicted survival. So if it was in hospital, neurological status at admission predicted survival, and then following discharge, age, and discharge to home predicted survival. Another thing to note was it was markedly increased mortality rates among the chronic subdural hematoma group. The median survival was 4.4 years, but it was predicted that they would live to 6, but because it was chronic, they only lived to 4.4 as a median. Another study looked at risks of traumatic bleeding with an increase or decrease based on the use of anticoagulation or antiplatelet medications, and it's actually disputed in the research. So the article that's listed with that point disputes the article that's listed at the top, and that was something that was pretty consistent within the research. So general demographics for this patient, she is 70 years old, female, Caucasian. Her primary language is English. Her education level is a high school diploma, and she is currently retired. Personal information and social history. Patient lives alone, previously divorced. Her daughter is currently staying with her during her recovery. As for other support systems, she has a granddaughter and friends that can assist as needed. She denies currently smoking or using drugs, and before the fall was drinking approximately 1 alcoholic beverage every 2 weeks. Her previous level of function was independent, and she was actually very active in social and recreational activities, specifically hiking and kayaking. Patient living environment is a single-story home with 6 steps to enter. She did not specify if there was any railing, but it does include acres that require land maintenance, and she does not use any assistive devices. Personal medical history includes type 2 diabetes, which is well controlled, hypertension, which is controlled, COPD, a heart stent, osteoporosis, and arthritis. Her family history includes hypertension and type 2 diabetes, but is unspecific as to who she gets that from. For the current condition and chief complaints, she experienced a fall after losing her balance reaching overhead at her home. She sustained a subdural hemorrhage and was hospitalized for 2 days. Patient presents to therapy approximately 2 months later. Her chief complaints are unsteadiness on feet, and she also reports being worried about falling again in the near future, dizziness, and headaches. Generally speaking, she didn't have a lot of pain to actually report. it was mostly the balance concerns and the headaches. So that's really all that was marked. So for the behavior of symptoms, the patient reports increased headaches and dizziness with challenging or strenuous activities such as driving long distances and walking on uneven surfaces. So in her yard is what she specifically mentioned. The symptoms also increase with fatigue or at the end of the day. So she differentiates headaches from brain fog. She describes it as difficult to concentrate, quote unquote, fuzzy or static feeling, but that it is tolerable. It's not necessarily painful. She also notes that it dissipates quickly with rest. Systems review, her vitals, cardiopulmonary and integumentary, were not formally assessed. Her height and weight were approximated to be 5'7", 170 pounds. For musculoskeletal, her range of motion was actually pretty unremarkable. Her upper extremity and lower extremity had good range. For manual muscle testing, bilateral hip flexion was 4- out of 5. All other lower extremity scores were 5 out of 5. Going into the neurologic, it was noticed that her fine and gross motor skills were impaired, but cognitively everything was still intact, so she was alert and oriented ×4. As for her functional status, she was technically independent, but still a significant fall risk. She had limited ambulation tolerance, just requires increased time. Her transfers were without any assistive devices or support, but she consistently swayed upon standing. Stairs were not attempted at the time of evaluation. She also completed an activity-specific balance confidence scale and scored a 46.88, which is a low level of physical functioning and confidence. Tests and measures, we specifically looked at coordination, so finger to nose was slowed, finger opposition was slowed, but rapid alternating movements was normal. For her balance, the Berg score was 23 out of 56, so she was definitely a fall risk. Static sitting was normal, dynamic sitting was impaired, static standing was impaired. Gait, she demonstrated poor balance, staggered steps, wide base of support, and difficulty with turns. Diagnostic hypothesis and classification, PT practice pattern from the APTA, neuromuscular specifically, pattern 5D, impaired motor function and sensory integrity associated with non-progressive disorders of the CNS, acquired in adolescence or adulthood. The ICD code, so specifically what the hypothesis is, she's still recovering from a traumatic subdural hemorrhage. I didn't necessarily quantify it as chronic yet, but that could always happen. Furthermore, she didn't specify a loss of consciousness, so an actual specification to the code wasn't possible. And then for further codes for treatment, there would be unsteadiness on feet, dizziness, and headache, which is also unspecified. Patient impairments include impaired balance, impaired coordination, and limited activity tolerance. So under this, we have without dizziness or headaches, and also inability to perform community and recreational activities. Her prognosis is fair to good. A couple of negatives is that she has some persisting symptoms that could be a sign of chronicity, and then also due to her comorbidities, diabetes, hypertension, and COPD specifically, progress in healing may be slower than anticipated or expected. A couple of positives, though, is that she has a good support system and appropriate cognitive status. She also has an appropriate motivation for therapy. The final negative, though, is that she's somewhat non-compliant to her safety recommendations and lifting pushing precautions. Patient goals included short-term that were 2 weeks, so patient will be independent in progressive monitored home exercise program and understand treatment rationale. The long-term were 7 weeks, so she'll be able to increase her Berg to 40 at a minimum. Patient will perform transfers independently and safely. She'll be able to walk for 60-minute duration safely, and then she will also be able to demonstrate appropriate balance reactions and standing to reduce her risk of falls. Plan of care and interventions. Patient was agreeable to 3 times a week, with her sessions being about an hour to an hour and a half. The interventions were going to emphasize fall prevention and training, balance coordination of both upper and lower extremity, power and strength, and then increasing her activity tolerance without the production of symptoms, the headaches and the dizziness. Therapy was also to include activities that address her personal recreational goals for hiking and kayaking. So again, specifically standing and walking on uneven and unstable surfaces. Procedural interventions were broken into three different categories. There's therapeutic exercises, therapeutic activities, and then neuromuscular reeducation. So for therapeutic exercises, we were initially limited by weight precautions, so we only progressed using body weight or minimal additions of weight for lifting and carrying that were less than 10 pounds. So examples of exercises were sit to stands, bridges, a piece of equipment called a total gym, or like a pull-off press for core. Once our precautions were lifted, we only progressed slowly with the intensities. So sled push pulls, a cable machine, or a leg press. And then for almost all of her sessions, we used a recline bike for her cardio, just increasing the time or the RPM is tolerated. And then again, once the precautions were lifted, increasing the resistance. For therapeutic activities, we would increase the range of reaching in all planes, also adjusting the weight and size of different objects. This was actually the most difficult for her because in some cases it would recreate how she fell. So she was pretty apprehensive to move outside her base of support or to really push her limits of stability. But once she got more used to it, once we started practicing in it, she became more comfortable. So other tasks included increasing difficulty of surfaces with foam pads or dyna discs. So we did a lot of obstacle courses and ladder drills. We would increase step heights, boxes using 2, 4, 6, and 8 inches. We would increase turning and weaving difficulty with obstacles, specifically decreasing the turning radius without loss of balance events. And we would also have her ascend and descend stairs with decreasing upper extremity support, so using both rails, then one, and then none. And then finally, we would increase the weight carried, the distance walked, and then changing gait variables, so step height, length, and direction, but we would utilize that along with farmer carries, suitcase carries, and waiter carries. For re-education, we worked on static activities, so introducing eyes open versus eyes closed and unstable surfaces. For example, using seated marching, and when, initially we would start on the table and then add a foam pad, and then finally working on a yoga ball in tandem and single limb stance, progressing to working on a foam pad as well. A lot of times with these static activities or with coordination activities, we would do dual task. So using cognitive load to make it more challenging. So math, games, visual scanning, basically I Spy, or even just general conversation. So for target coordination, we would change the target distance, size, and then even support, upper extremity support that she could use to reach her goals. Another example would be ball catching and throwing with a partner or against a wall, and again, adding cognitive steps to complete the task. So for overall results, with the precautions, she had an increased use of balance strategies, increased overall activity tolerance without an increase in symptoms, and then increased safety with her transfers. After the precautions were lifted, she also was able to modify and provide appropriate attention to her activity responses. So especially the first session after we increased the activities, she reported a bigger headache than usual. But the alternative side to that is that her morale increased significantly with return to more functional tasks and activities. And then at the time of this report, patient increased Berg to 24 out of 56, and then her ABC scale to 60. So technically she's still a fall risk, but she is gradually improving. Furthermore, her goals are still demonstrating really good progress. Proposed recommendations for future research, treatment dosage, and recommendations for intracranial hemorrhage cases just in general. One of the things that was emphasized more was inpatient treatment. So in the hospital stays, in the ICUs, how often were people being treated, how much were they getting, versus seeing someone in outpatient as they're recovering. Another topic would be optimizing balance strategies for fall risks and patients recovering from traumatic brain bleeds. Blunt CVA, CVI, in geriatric populations, and appropriate treatments in those cases. Another benefit would be screening for chronic subdural hematomas, and related to that is appropriate timelines and expected recovery periods for acute hemorrhages.